Welcome you all, and thank you for joining the second panel discussion of a two-part program featuring panelists who will provide their perspective about how the pandemic is affecting Black, Brown, and Native pregnant people. My name is Nikisha Jones, and I serve as project lead of the National Maternal Health PCOR Network, which is an initiative funded by the Patient-Centered Outcomes Research Institute, also known as PCORI, and is housed at Health Resources in Action, a public health nonprofit based in Boston, Massachusetts. I am joined by my HRA colleagues, Lauren Onsong and Naniqua Blanding, who is helping to facilitate today's discussion, and also Kelly Dankard, who is helping us with social media. So please tweet hashtag NMHPN chat and equity in pregnancy. Lawrence is sharing this information in the chat box. And while you're there reviewing that information, please tell us who you are and where you're joining us from today. The network exists to collaborate across many sectors to respond to inequities and adverse outcomes in maternal health, including historic and structural racism in maternal care. Yesterday, we were joined by grassroots leaders and researchers who shared specifically about COVID-19 and racial inequities, and about the challenges of providing care in a system that was not built for Black, Brown, and indigenous birthing people and their babies to survive. Today, we're speaking with some of our network members and a guest to discuss what they are seeing regarding the impact of COVID-19 on the communities they provide care and support to, and what we should be thinking about, supporting, and organizing our work around to protect pregnant people, while also protecting the healthcare workforce and the community supports. And just a reminder, please enter your comments in the chat box or use the question feature to submit questions, and feel free to address your comments or questions to specific panelists. Our panelists today include Dr. Joya Creer-Perry. She is a thought leader, speaker, trainer, advocate, and policy expert around racism as a root cause of health inequities. And she is also the founder and president of the National Birth Equity Collaborative. Dr. Creer-Perry is a fighter for justice and currently serves on the advisory committee of the Black Mamas Matter Alliance. She is also a principal of Health Equity Cipher and serves on the boards of trustees for Community Catalyst, the National Medical Association, and the California Preterm Birth Initiative, housed at the University of California, San Francisco. We also have Dr. Kenesha Bryant-Moore. She is currently the Assistant Dean for Diversity, Equity, and Inclusion, and an Associate Professor at the University of Arkansas for Medical Sciences in the Faye W. Boozman College of Public Health. Dr. Bryant-Moore has been a nurse for over 20 years, providing direct patient care and health education, and is also a health disparities and inequities researcher. Presently, she serves as the co-director of the Community Engagement and Dissemination Core of the Arkansas Center for Health Disparities, which is funded by the National Institute of Minority Health and Health Disparities. We also have Dr. Neil Shaw joining us today. He is an assistant professor of obstetrics, gynecology, and reproductive biology at Harvard Medical School. He also serves as director of the Delivery Decisions Initiative at Harvard's Ariane Labs, and he is also an obstetrician gynecologist at Beth Israel Deaconess Medical Center in Boston. Dr. Shaw cares for patients at critical life moments that range from childbirth to primary care to surgery. In 2017, he co-founded the March for Moms Association, a coalition of more than 20 leading organizations to increase public and private investment in the well-being of mothers. Dr. Shaw currently serves on national advisory boards of the Planned Parenthood Federation of America and the Office of Women's Research at the National Institute of Health. We also have Dr. Noelle Reed joining us today. She is a board-certified family medicine physician and is the founder and medical director for Trinity Health and Wellness Medical Group, a family practice and wellness center in Los Angeles, California. Dr. Reed is a trained dancer and certified yoga instructor. She blends these passions into her medical philosophy and holistic approach to health, and has made movement a focal point in her practice by incorporating yoga, dance, and Pilates as a means of treatment for her patients. She has made numerous contributions to news publications such as the Huffington Post, LA Magazine, and First for Women magazine. She's also a recurrent guest and medical contributor for Good Day LA and has been featured on the Doctors TV show and Bravo's hit TV show Married to Medicine LA. And lastly, we have Vanessa Tibbetts. She is an enrolled member of the Oglala Sioux Tribe and serves as the program leader for the American Indian Public Health Resource Center at North Dakota State University. Vanessa has worked in public health for the last 15 years with tribal nations, focusing on various topics, including commercial tobacco prevention, maternal and child health, and utilizing culture as prevention. Vanessa works to serve American Indians using the skills she has acquired professionally through academia and through her elders for the future of her people. And unfortunately, Mariah Cronz is unavailable to join us today. And before we begin, we want to acknowledge the time these individuals are providing to us today. They took time out from their schedules to participate in today's discussion. And for that, we feel very special and are very grateful they joined us today. So we're gonna go ahead and get started. And Dr. Creer Perry will direct our first question to you. We are about 2 months in since COVID-19 was declared a pandemic, and there's still a lot we do not know about this virus. It has exposed a fragile U.S. healthcare system and has caused existing vulnerable safety nets to weaken further. Tell us, how has COVID-19 affected delivery of care, and what are your top concerns?
Well, thank you. I just want to once again thank HRIA for inviting us and for being a part of the network. It's been really enjoyable to work with you, Nikisha, over the last couple of years and your team. So I just want to thank you for putting this on. So COVID-19, we know, is exposing what we really had already been learning and knew in this Black maternal health crisis, that although the virus is a biological thing, so it moves across based upon biology, and it doesn't, we have biases around race and class and gender. And so those biases, the virus exposes, and the virus is able to really use those crevices and those breakdowns in our systems where we devalue groups of people and uses an opportunity to spread more rapidly. So although it's only a vector and it doesn't have a brain, it does have an ability to capitalize on the fact that we have not valued certain groups and that we don't provide things like safety net insurance for people. There are still way too many uninsured folks in the United States of America, so they don't know that they have a pre-existing illness and if your primary mechanism for telling people what to do is to say contact your provider, and you have millions of people who don't have a provider, who've never had a provider, then you're gonna have great differences in outcomes. We know that birthing people are being separated from their families, they're being separated from their babies, and there's a lot of concern around what do we do? I'm really worried about what happens when we are going to virtual care. Who's deciding who gets virtual care? Patients are confused about when to go to the hospital, about what are the things that they're supposed to be concerned about without having that. We created a system that's built upon interaction in person, and now we're doing it virtually, and we have not created a system that knows how to do that. And so you will see the differences that we've created in value play out by who has access to care. So that's it.
Thank you, Dr. Creer Perry. We really appreciate that perspective. Dr. Bryant Moore, please share with us.
Yes, and the work that I've been doing here in Arkansas has been primarily with women who are homeless or facing housing insecurity, as well as teen moms. And we had at the university a prenatal education program specifically for this population that we have actually had to suspend until we feel like things are safe to bring women out, which unfortunately these group gatherings was something that the women really relied on as support for each other. And people say, well, we can do video conferencing, we can do telephone, what have you, but when you're working with a population that is already under-resourced, a lot of our women don't have phones that have unlimited minutes, unlimited data. So unless we're providing that for them, they really are still disconnected. And oftentimes they are switching their phone numbers for even for us to to be able to track them is definitely a challenge. We also at the university, we just gave the thumbs up last week to be able to start with elective surgeries, but that is on hold now until we find a policy in place that, or a practice in place that keeps everyone safe. So I know we plan to do COVID testing 24 hours at least before someone comes in for surgery, such as a C-section, to make sure that they're okay. But then they're also limited to who can come to the hospital with them. And everyone is required to wear a mask and be screened before they can come. So we're still seeing a lot of challenges with that. And with telemedicine, again, the issues with the phones and access to a computer, we're seeing that there's a lot of trust issues. And then we're seeing a lot of women who are delaying care. So there may be an issue, there may be a problem, but because of that fear of potentially being exposed to COVID, they aren't coming necessarily to the clinics when they need to.
Thank you so much for sharing. Dr. Shaw, please share with us.
Sure. Thanks for having me. I'm trying to think about what I can really add to our co-panelists who I think have stated the issues really well. I mean, maybe what I can do is just say what my lens is on this, which is you know, for everybody who's in Boston on this panel, you know that this week, last week, the coming weeks are probably the hardest that we're going to see. We're flattening our curve, but we're at the top of the surge of our city. So, you know, I'm a forward deployed obstetrician. I'm working in an inpatient environment where in our health system, we have about 800 people at any given moment that are COVID infected, and those are the people who are sick enough to be hospitalized. Pretty much every day, on the basis of just examples and counterexamples, we see cases that really modify our understanding of what this virus is, how it works, how it can work. I think one thing that I think I would add is that for everybody that's sort of working in these environments, we're seeing things that really outpace what the media can report or what academic journals can really weigh in on, and have to make really difficult decisions based on a really fundamentally shaky understanding of what is possible, but in ways that we hope are aligned with our values and ultimately what we're trying to do. The other lens that I have on this is deeply personal. It's scary to go into the hospitals. It's weird. I will say that all the interstitial spaces in the hospitals are essentially empty, including the emergency room. Everybody is scared to come in. But certain parts of the hospital are extremely busy. We've had to convert and repurpose spaces instead of field hospitals inside of our lobbies to accommodate the COVID patients. And then labor and delivery does not slow down. And in fact, the need to screen and test and isolate people who are infected have really exacerbated the bottlenecks as you know, simultaneously staff are getting ill. Labor and delivery requires physical contact. I share Joya's concerns actually about what we decide to make virtual and not, and for whom. But there's no way of caring for somebody in labor and supporting them in labor without being up close. And during the second stage of labor especially, the entire process is aerosolizing because the normal work of labor requires grunting. There's fluids, there's surfaces, and you know, it's not entirely clear that our PPE is adequate. The other part of my personal lens is I've got dear friends and family who are in endemic areas that are even worse than mine, living and working in Queens, in Newark. My mom's a dentist, still attending emergencies without PPE. My friends in Queens at times they only have garbage bags to sort of protect themselves. So I say that just to anchor my lens is really being up close and personal with some of the difficulties of this. The other lens that I have that I think really informs my view is that in my Ariadne role, I'm aiming to support both healthcare systems and social safety nets and really communities in, you know, reliably taking care of people. And one of the things that I'm very concerned about is that there's been a long-standing challenge that a lot of our co-panelists have alluded to, where the people that our systems have failed to really care for are understandably distrustful of those systems. And as they're watching us make all of these really rapid decisions, and I say us because I'm an institutional actor, I'm part of that, we're asking people to isolate at home who are, you know, the people who are calling infected that we're telling to self-isolate are the least able to self-isolate safely in the first place. And they feel really dismissed when we tell them that they're not sick enough to come in. I know from my daily interactions that when people come to the hospital and they see visitor restrictions, they feel effectively policed. And when they see us making decisions about how we're prioritizing people for testing, let alone treatment, they're feeling essentially condemned. And that's a really big problem. So I guess what I'm hoping that we'll get into is how we fix that, because if we just wait this out and hope to return to normal, we're going to enter into a world that's even less equitable than the one that we started this pandemic with. And the only way through it seems to be visioning through it and establishing a new normal.
Thank you, Dr. Shaw, for sharing your lens with us. It was really good perspective. Dr. Noel Reed, please share with us.
So I would say, you know, moving into this COVID season, it definitely has forced me as a community physician to change the way that I deliver care. And that means that relying heavily on telemedicine. I would say that approximately 90% of my patient encounters right now are virtual. We do still see patients in person, but that's a challenge as well in terms of triaging appropriately to figure out who needs to come in and who doesn't. And of course, when they do come in, it's a different experience. We are masking and gloving for every patient, regardless of symptoms or what they're coming in for. So that also makes the energy different, you know, when they come into the office as what it has been prior to COVID-19. For my pregnant patients, so as a primary care physician, I'm not following them through the entire pregnancy. I essentially see them initially to confirm pregnancy and then refer to OB, and I see them in the postpartum period. And of course, during the pregnancy for non-pregnancy related conditions, such as respiratory infections, mood conditions, anxiety, depression. So what we are doing with our pregnant women essentially are virtual visits for right now. So we essentially have them test at home, and we do the initial consultation, and during that consultation kind of prepare them for what they may be up for during the pregnancy, and that perhaps being that they will have continued virtual visits or perhaps only come in at certain critical stages of pregnancy, perhaps not be able to be with their loved ones or their partner during visits as to minimize, you know, human to human contact. So just kind of preparing them for that. And I would say that one of the challenges that I see as a physician and business owner is sustainability. Because, you know, as it stands now, we're essentially working at 50% capacity because we cannot see everyone, of course, in the office. And so a lot of our wellness visits, our physicals, well woman exams, pap smears, we're not doing right now. And so my concern as a solo practitioner and for other community physicians that, you know, rely on patient care, how we're going to be able to push through and still continue to offer care, you know, in allowing us to continue to be able to take care of the lives, as well as continue to employ people. So, you know, a lot of what I do in my practice includes physical therapy, Pilates, and yoga therapy. Well, those therapists aren't able to work right now. So my concern for their families is they're able to kind of be resilient during this time as they're not able to be employed, and if we can continue to make it and push through. In addition, because we have to utilize more PPE, that's a higher cost for us, you know, and the prices are more these days, significantly higher than they were before. So that is a challenge. And then from a clinical standpoint, what I'm seeing probably more than physical ailment is mental illness. So a lot of anxiety, a lot of depression, more suicidality, you know, literally having to talk people down from the ledge. And that has been a challenge where we're having to do this primarily telephonically, you know, through these virtual visits. And then those who have chronic conditions. So high blood pressure, diabetes, heart disease, and being afraid to go into the ER, being afraid to go into the urgent care, and trying to calm their fears and let people understand and know that COVID-19 is not the only killer right now. It may be the #1 cause of death, but as it stands now, but there are other things that can certainly cause morbidity and mortality. And so getting them to understand that when you need to go in, you need to go in. And that, those have been some of the challenges that I've been faced with during this time.
Thank you. Really appreciate that perspective. And Vanessa, please share with us.
Sure. So I think with a lot of our tribal communities, COVID's really impacted us because we've already had a lot of challenges at baseline with a lot of health disparities like diabetes and cancer and alcoholism and suicide, depression. So it's really made it a lot more challenging with our tribal communities. And then when you talk about how diverse different tribes are, we have like 573 federally recognized tribes. And so each of our tribes is a little bit different as to how they're addressing the topic and what resources that they have access to. But overall, from what I've heard from a lot of our tribes is that there's a complete lack of resources for healthcare delivery, especially in regards to COVID-19. And then when we talk about maternal and child health, some of our tribes are in very rural communities, so they have to travel long distances to get prenatal care. So now with COVID happening, they're missing even more appointments due to not being able to leave their communities or being too scared. So it's really limited access to services. Another concern for us, or for some of our tribes, is that some of our tribes don't have access to basic necessities like running water and even like internet, or phone service. So how is telehealth going to work when they don't have those basic needs? And then how are you going to protect yourself if you don't have running water, so you can't wash your hands? And then also talking about families living in multi-generational homes. So you might have a family with, several different a home with several different families living in it, with grandma, aunties, and then you have a parent with their 3 kids and they're all sharing a bedroom. So you really can't quarantine because there's just no space. So those are some of our challenges that we've been talking about with our tribes.
Thank you, Vanessa. We really appreciate hearing from you. So our next question, Dr. Bryant Moore, we're going to start with you. We know that maternal and birth outcomes are closely linked to social determinants of health. What supports were in place before the pandemic to improve outcomes, or how were resources being coordinated to help patients meet their needs, such as housing, food access, and transportation to medical appointments? And how has COVID-19 exacerbated existing challenges? What are the disruptions? How is care currently being coordinated? Please respond. And I know that some of you have already touched on some of these, but we look forward to hearing from you.
Yes, I won't repeat some of the things I've already shared, but when working with women who are homeless and housing insecure, a lot of people obviously have been losing their jobs or have been cut hours, furloughed, what have you. At least in our state, we haven't had any policies around no convictions due to these things. So I'm working with a population that's already under stress, and due to lack of the ability to work or what have you, now they're at greater risk, even if they had a home, to lose it because of potential evictions due to loss of income. Another thing that we're seeing, I work heavily with the faith community in Arkansas around providing resources to communities, but many of the faith communities are also kind of shut down during these times, providing services, religious services online, but often some of them, quite a few actually, have not continued to provide meals that a lot of these families relied on. And a lot of the food bank places, they're doing drive-throughs. So they'll have a pre-prepared box for you, and you drive through and you pick it up. But if you don't have a car to drive through with, then how are you going to pick up the box? And even if you walked in to get it, how are then you going to get it to where you need it? Our transportation system was already broken. Even before we were using Uber, and now because I know people are not cleaning these vehicles down after every passenger, it's like I don't feel comfortable ordering Ubers for the women to get in at this point. I don't feel comfortable telling them you have to get on the bus for your public transportation. So being pregnant and then getting out and being in the mix is just make it even more challenging. Thank you.
Thank you. Thank you for that perspective. Dr. Shaw, please share with us.
Well, just this morning, actually, we were on the phone with some partners of ours in the heartland of our country, closer to where Dr. Bryant Moore lives in Arkansas and Oklahoma. And in particular, we're thinking about people in Tulsa, where, you know, there's a long-standing history of violent racism and standing structural entrenched disparities, and trying to think about how the services that were, you know, they also benefit from having a lot of philanthropy actually in the city, and a lot of community-based organizations that have tried to sort of shore up where the Oklahoman government does not necessarily have the most robust social safety net, but at least within the city of Tulsa, there's a number of extraordinary community-based organizations. And I think, you know, one of the things that is challenging is that the social mitigation measures to prevent spread of the virus in some ways are as harmful as the virus itself, which is a really hard tension to hold. But yeah, like if you depend on mass transit to work, that's certainly what happened in New York City. That puts you at extreme risk. If you live in multi-generational housing, whether it's in Tulsa or in my own backyard in Chelsea, actually the hardest hit community of all of Massachusetts is Chelsea, and it's primarily because of immigrant families living in multi-generational housing who can't really isolate and live with vulnerable people. And it tends to be moms and caregivers that are primarily impacted by that. You know, I don't have I wish I had a way of clearly articulating the way through this. I think what gives me a little bit of hope is that I think a lot of the structural challenges that people were able to ignore are very hard to ignore right now because they're so stark. And I think with attention and focus and advocacy, we can really bring those concerns to the fore right now as we're trying to restructure so much social policy. And I think, you know, the other thing that we're going to have to contend with is that the risks that we're seeing, especially the social risks, they're likely to wax and wane, you know, in the months ahead. It's not the case that we're all sheltering in place for a little while, and then, you know, and then we just go back. What is much more likely is that Oklahoma will turn on restaurants again, and Georgia will do that, you know, well ahead of when it seems clearly safe to do so. But even in other parts of our country, because food supply chains are being disrupted, like Tyson Foods, apparently in Arkansas, supplies 1/5 of the country's meat. And, you know, at some point, they're just going to have to turn back on. And so we're going to see these waves. And as we try to figure out how to protect people from a housing security standpoint, a food security standpoint, that just dynamic nature of this is going to be part of what's complicating about it. It's going to require a lot of nimbleness and agility in the way that we provide services. It's really quite different. And the note about putting people on Ubers really strikes me, because I'm hearing solutions like, in lieu of mass transit, maybe we should really turn to ride sharing. But if you really think that through, the practicality of really wiping down an Uber every time is very concerning, and I would have the same concerns as Dr. Bryant Moore. So we definitely have to continue to be thoughtful and innovative.
Thank you. Thank you very much for that perspective. And Dr. Reed, please share with us.
I would say that in terms of social services, our social network, I have been blessed to be aligned with and contracted with health plans that have been very helpful in that regard. So they have, you know, entire departments to aid us with social services. Prior to COVID-19, we actually would have representatives come in on a weekly basis to help us with social support. So whether that be for transportation, interpreter services, food access, mental health services, that was made available to us. During this time, we've had to transition primarily to doing, again, electronic submission. So what we were doing before was the initial transmission being electronically, phone calls to initiate care. And now that's primarily what we're doing during this time. And that actually has allowed for us to continue to offer services to our patients. So I wouldn't say that there has been a significant drop in our ability to provide these services from our end. Now, what I am seeing from the patient's end is the fear. So if it does require for someone to come into their home, let's say they need in-home supportive care, or they need OT-PT to come to their home, physical therapy or occupational therapy, they're refusing it. And that's where I'm seeing the barrier, is that the patient just doesn't feel comfortable because of risk for exposure. And so trying to kind of get around that and still allow for them to have these services available to them has been somewhat of a challenge.
Thank you. Thank you, Dr. Reed. And Vanessa, please share with us.
Hi. I think, you know, it just aligns with what the rest of the group said. Our tribes have a lot of great programs that have been in place to help address maternal and infant health. And now that COVID's hit, a lot of those programs aren't able to do what they were meant to do and able to be providing that social support. And I think that's missing with a lot of our pregnant mothers right now, is that they don't have those ways to get the support other than virtually with like social media. But like culturally, we have things like sewing circles, and we have ceremonies where we, you know, make for the baby's first laugh and things like that. And those things aren't happening anymore. So it's like, it really just kind of, it leaves us in a spot where we're like, what do we do now? And so it's kind of traumatic, actually. So I think our families have really been dealing with that, and even mourning, you know, how do you mourn in a time like this when you have to practice social distancing, when that was so much part of our culture. So we've really just been, you know, trying to reach those supports with our life, you know, our schools and our churches, and they've been super supportive in our tribal communities, like getting food to the kids and being able to provide those services. But what's really lacking is, again, it's being able to get tested in our communities for COVID-19, because there's such a lack of testing, especially in the Northern Plains area, because, well, we've obviously haven't been hit very hard yet. So, you know, a lot of our tribes haven't even gotten tested. So we don't know where our status is. And a lot of our people are really scared because, you know, just with history of intentional, being intentionally infected with diseases such as smallpox blankets being distributed to our people, and our populations have been wiped out due to viruses like this. So I think our people are really scared. and we're losing our social connections, and it's really starting to impact the way services are provided.
Thank you. Thank you. We really appreciate hearing from you. Dr. Kerr-Perry, please share with us.
I mean, everybody said such great things. I just want to give just a little bit of framing because that's what I do. So the social determinants of health are not something that we address inside of healthcare in the United States at all. We don't have a right to health. All the other high-income countries, there's 37 others who have agreed to a right to health. And what that would mean if we agree to that is it's not a conversation about how it's administered or what it looks like if it's insurance companies. It means that we would agree that you shouldn't have communities that don't have access to testing. It would mean that we agree that you shouldn't have hospitals that don't have the proper PPE. It would mean that we would agree that we should have paid leave and we should have childcare. So believing that all people have value and health is a right for everyone, to make us as a country really be exceptional and great as we always have been, is to really lean in to say we believe that all people, despite income, religion, ethnicity, race, should have the right to health. And so these conversations, we started getting transactional about who should get what thing and who needs what service versus us all. I hope we come out of this moment expecting a deeper appreciation for the social determinants of health are not something that each individual person is responsible for, but we as a country have to come together to believe that we all deserve to have these things.
Thank you. Thank you so much. We're going to go to our next question, and Dr. Shaw, we'll start with you for the next question. The postpartum period is a critical time in monitoring the pregnant person's health. More than a third of maternal deaths occur during this time, and it is much higher for Black and Native people. Social networks are a point of strength and resiliency for these communities. For better or worse, in managing this virus, COVID-19 has essentially cut off social supports. How is maternal health being affected as resources are diverted to combating the virus? How is the delivery of postpartum care impacted? And how are pregnant people's mental health being monitored and cared for during this time?
Thanks for asking. I mean, I think the opportunity here is really to highlight the unique vulnerability of people who've just had babies, because all of us who are on Zoom right now are aware that, you know, we're isolated. I'm sure it's getting to all of us. It's been weeks and months, but then, you know, there are ways that people who have just had baby are uniquely vulnerable that I think for some reason, compared to other things, we as a society are less empathetic towards. And I don't know if it's because we all have babies or we're all born at the very least, or it's because, I don't know, we just have a societal expectation that moms in particular put their own well-being last in order to put their families first. But compared to literally every other critical period in people's lives, compared to other health events, we normalize the status quo around childbirth no matter how bad it is, or how difficult it is. We just sort of expect that everybody sucks it up. That was sort of the baseline condition. And the baseline condition, to be completely clear, was a case where, you know, you're getting POW level sleep deprivation. You can't do anything with your hands. Especially if it's your first time around, you're sort of existentially terrified anyway. And trying to keep another human being alive. And then what Dr. Kerr-Perry said, what really underscores it, is that one of the cruelest features of our whole healthcare system is that right now, if you get public insurance, you know, 2 months in to having a baby, when you're literally at your nadir in terms of sleep deprivation and all the other difficulties, we can pull the rug out from underneath you and end your coverage. Which is literally, in my opinion, probably one of the cruelest features of our entire healthcare system. And then you compound all of that with not being able to have your support or your loved ones, your grandparents, siblings, or neighbors. I mean, like the most helpful thing that people did for me after we've got 2 toddlers at home, it was like our neighbors just brought us coffee, you know, but that's not a thing that is recommended right now. So all that's to say is and then, you know, as you were alluding to, it's a period partially because of all those difficulties and partially because of additional circumstances where people are very vulnerable from just a mental health perspective. And we know that the plurality of people have diagnosable mental health challenges that our system is really inadequate at supporting and responding to under baseline conditions. All of that's been exacerbated. I'll also say that during every humanitarian crisis in the history of the world where we've documented such things, maternal health has suffered. And it's because there are a lot of essential services that don't seem like the priority because they're so routine, right? We really go towards the acuity in the COVID units, but we sort of forget that maternal health is essential. As I mentioned, the labor and delivery unit is as busy as ever, and the resources get shifted elsewhere, and pregnant people get deprioritized. That's true at baseline, and what we're seeing at this moment is really being compounded by the fact that people are going through this experience so isolated. I'm hopeful that we will find ways to support people nonetheless. To get there, I mean, part of the answer is making sure that we are not socially distant from each other, even as we're physically distant, and trying to maintain connections by whatever means we can. I want to give a shout out to my colleague, Chanel Portia Albert, who's a doula in Brooklyn and has just done an incredible job of pivoting in real time and not only providing virtual doula services, but training up others, including RNs, to provide at least some level of service. So we'll need more of that.
Okay, thank you so much, and thank you for the shout out to that doula who is transitioning and offering supports in real time. Dr. Reed, please share with us.
So certainly the postpartum period is a critical time, and that's typically where I pick up care. My patients usually come back to me at that point, and you know, I'm usually the point person, or I co-manage with the OB during the postpartum period. And I would say that, you know, what I am trying to make sure that my patients understand during this time is that although we are distanced, we do not have to be disconnected. And so that means that we have to really lean into the technology that we do have. And that means either by phone or by Zoom or what have you, to continue that communication. And I think that is what we're going to likely have to continue to utilize moving forward, because I do think that what COVID-19 has done is shifted us into a new paradigm. So life is not the same. We are likely not going to ever go back to where we were before. And so that means that we have to augment things and augment the way that we access healthcare, but also how we are giving healthcare to our patients. And that likely is going to be that we're going to have to utilize technology even more so than we ever have before. And so I would say that what virtual medicine has done for me at this point is really allowed for me to communicate more so with my patients, especially for my complicated ones. And it can be challenging when you need to see someone, let's say on a weekly basis, to get someone to come in an in-person visit on a weekly basis. There are so many barriers that exist. But oftentimes virtual medicine allows for us to minimize that, because essentially if you consider transportation being lacking, or someone can't leave their home, or they can't leave their job, or let's say they have shifted and moved to a new county or state and, you know, cannot physically see you but want to continue that connection, telemedicine allows for us to continue that connection. And so I've really been leaning into that during this time. And as I mentioned prior, a lot of my visits are mental health. And I would say that you can effectively still treat in that method in terms of going through the proper evaluation, deciding what perhaps medications will be helpful, changing or titrating those medications, and as well as doing behavioral things such as pranayama or breath work, which I do often with our patients, just taking them through a breathing exercise. All of these things can be done telephonically. They can be done on the phone. They can be done virtually. So that's what I'm leaning into at this point. And I think that's kind of where we're going to be shifted. And it's just a matter of us accepting that, you know, accepting our new normal and learning how to be more effective and efficient in how we deliver care moving beyond COVID-19.
Thank you. Thank you very much for providing that perspective. Vanessa, please share with us.
Not to jump on the telehealth train, but I think, you know, that's really the way that we're leading to, where our center is partnering with HRSA to hold a virtual telehealth conference to invite our tribal nations to learn more about the benefits of telehealth and how we can help bring that to their tribal communities. Another thing that we're doing, this is just North Dakota state focused, is we're also working with the Department of Health. We've become a part of a Medicaid task force to work on efforts to expand Medicaid after birth, after 1 year. So we're hoping to expand our Medicaid to help our families to get those services that they need in the times that they need it. So yeah, that's all I have to say.
Thank you. Thank you very much, Vanessa. And Dr. Kerr-Perry, please share with us.
Oh, I'm not muted. I thought I was, sorry. I'm glad that my son didn't interrupt y'all. My fake third grade teaching that I'm doing is not very effective. So yes, I am, telemedicine is really critical. The irony of this telemedicine conversation for me, once again, is that I was at FCC 5 years ago trying to get telemedicine for rural communities, for Black low-income communities. So shockingly now everybody's on the telemedicine train. So great. So now that we're here, how do we build it out more effectively? Because we've always needed it, because people work and they can't sit in your office for all day for a 15-minute visit. So it's really great that now we're all on board, that there should be other alternatives for how we receive care. So now our task as healthcare providers is to make sure that it's appropriate and efficient, and to modify. We can use examples of others like Dr. Reed, who's already been doing it, to say, okay, well, what are some lessons you've learned, and who should come in and who shouldn't, and how do you evaluate? And I mean, those are the next important questions, but we're going to have to and I do think the new norm will be less in-person care, because people are becoming accustomed to, I don't have to sit there all day to wait for you to talk to me for 15 minutes. They're not going to want to go back to having to do that again. So we're going to have to modify how we even experience our care, especially for postpartum moms who, they were home with the baby. We talk about getting insurance 2 months later, but we want them to come in and get a pack of pills. Why would they need to come in to do that? So there are so many moments around, how do we really rethink what we were requiring of people to do, and to what end, and how did it benefit them to have to come in to be seen when they need support and they need us to support them. There are a lot of ways to do it. There were some questions around two things. One was, yes, we're seeing an uptick in home births. Yes, we have doulas in the networks, and centering is still going on virtually across the country. People are still figuring those things out as well. So.
Thank you. Thank you very much for sharing that. And lastly, Dr. Bryant Moore, please share with us your perspective.
Sure. A lot has been shared around telemedicine. So I totally agree. And especially being in a rural state, this is something we've been advocating for a long time. And again, I lean heavily, being a public health worker, on our community partners. And so was looking at the different organizations, such as the Arkansas Birthing Project, which is actually an international birthing project, is international. But having this big sister, little sister connection, having these moms who have been through it connected to these new moms or these younger moms, and being a support for them, it continues regardless COVID-19 or not, through check-ins, sending care packages, what have you. Unfortunately, even before all this, mental health has been a huge stigma. And people, even though if they realize something is not quite right, still are reluctant to go to their healthcare provider. We heavily, again, work with the faith community. We often talk about pastors being first responders when it comes to mental health, but making sure that they are equipped and have the training, they have the resources that they need as well. We have several programs around that we can connect some of our young ladies to as well. But again, in the midst of this, we're still dependent on that technology that unfortunately a lot of the young ladies that I work with, the women I work with, still have some of those challenges.
Thank you, Dr. Bryant Moore. Thank you so much for sharing your perspective. And we have one more question, and before we get into our last question, I just want those of you who are in attendance to please submit your comments. Use the chat box to submit your comments and the Q&A to submit questions. We'll try to get to as many as we can. I mean, we are sort of down to just a few minutes left in this program, but hopefully some of our panelists will be able to respond to your comments directly in that form. And so our last question, and we're going to start with you, Dr. Reed, is from your perspective, what is your unique role in addressing this pandemic, and what is the path forward?
So I think as a clinician, we certainly play a vital role, for sure. I think that we have been called upon to do more than we ever have. We certainly are, or rather should be, healers, for one. But I think definitely during this time, we have had to be educators, because more so than anything else is getting the right information out. And that alone could be life-saving during this time. And then also giving it in a form and fashion, finessing it to the point where it does not provoke anxiety, you know, and there's a fine balance between that. So being very careful and conscious about how you actually disseminate and present the information. In addition to that, I think that we have also been called upon to be sources of inspiration and hope, because we're all looking for that right now, right? We're all in this together, for sure, and all, you know, suffering during this time. And I can say definitely from my patients, what I see is that they just want to be lifted, you know, giving them some sense of hope and that there's a light at the end of the tunnel, and how do we get through this together? And so I think that we have just really been forced to be better versions of ourselves during this time, and kind of carrying all of those things and wearing all of those hats. In terms of moving forward, and when I think about advocacy, it has been made very clear, you know, what disparities exist within Black and Brown communities. Unfortunately, these are disparities that have not just appeared. They have been present for decades. It's just now that COVID-19 has allowed for the masses to be made aware of it, which is a good thing. But I would say that one of my push points would be for increasing representation in terms of those of color who don the white coat, because I think that also impacts how care is delivered. And, you know, there's so many factors, and we can have a whole nother hour conversation about what has really caused these disparities to exist. But one of those things being the disparity in representation. You know, when we look at the numbers where only 5% of those that are practicing medicine in this country are African American, that only 5.6% are Latinx, that only 2% are African American and female. That is a problem, you know, and that has not shifted for years. And so I think that one, just being seen, having discussions such as this, so that people understand that we do exist, and that our youth hopefully can see us to know that we exist, so that perhaps that changes the consciousness of those to know what's possible for them, so we can improve upon those numbers, to improve upon what we're seeing in terms of the delivery of care within our country. So that would be my push point moving forward, is improving upon the representation within the healthcare industry.
Wow, thank you. I think we all can agree to everything that you just said about representation. That's very important. And so Vanessa, please share with us what you think the path forward is.
Sorry, I was on mute. Very much so in the framework of what she just said. Since I work in public health at a university, I'm really all about spreading the word of public health to our Indigenous populations. You know, getting careers in public health or medicine. Our sister college, the University of North Dakota, has a program called Indians into Medicine. So getting more Indians into those healthcare fields, American Indians. We also offer a public health specialty in infectious disease. And I'm like, our tribal nations need to be aware of these programs, and that most of our classes can all be offered online, so they don't have to leave their reservation. They can do their practicums in their tribal communities. They can do research in their tribal communities and stay where they're needed in their tribal communities. And then again, with my public health hat, I'm also a researcher. So I keep thinking about assessments during this time of COVID-19 and looking at how it's been impacted our tribal communities. So how have services in relation to maternal child health been impacted due to the COVID-19 response? And a lot of our tribes have state of emergency declarations, as well as our states and cities. So how has that really impacted the health of our young mothers? And then also looking at assessing communication and communication systems with pandemics like this, because again, we are those people that are, you know, giving out facts that are from the CDC and not rumors. So making sure that the right information is going out to our communities.
Thank you, Vanessa. And Dr. Kerr-Perry, please share with us.
Yeah, so I think building on Dr. Reed's point around health inequities, although they were shining a bright light on them today, during COVID-19, this is an opportunity for us to really change our overlying framework as the United States of survival of the fittest versus the least of these is as important. So what we normally do is point out to these differences in who died during a pandemic, or in my case, during Hurricane Katrina or other disasters, and we blame the individuals. We blame their behaviors, their choices. We say, oh, well, they eat too much Popeyes, or they went to many parties, and we don't really look at the underlying root causes of racism, classism, and gender oppression. And so when we are allowed to just blame individuals and their behaviors and their choices, and not looking at how we devalue groups of people and what can we do together, the path forward is for us to all realize patients, providers, communities, we're all in this together. We're all not getting what we're supposed to have coming to us. We're all not getting our due. We are having to, as providers, figure out how much things cost. That shouldn't be our role. We should be able just to care for patients. And we have created a system that says we are all pitted against each other. So I'm hoping the path forward is a unified belief that we're all in this together, and the least of these are just as important. And how do we build policy and a culture that supports that belief?
Thank you. And Dr. Bryant Moore, please share with us. And I'm acknowledging the time, it's 4:58, so we'll try to get through this as quickly as we can.
Yes, and I think what the other panelists have said, I totally agree. And I love the bandwagon of the public health, so I'm going to ride it a little bit more. I think it's just been revealed to us that we do not have a strong public health infrastructure within the United States. And I think, if anything, that is something we need to learn from and build upon in the future. And I mean, we talked to people in the community. We said, well, these are guidelines from the Center for Disease Control. A lot of people didn't even know what I was talking about. And so we have to make sure people are educated before a pandemic happens, that we have the infrastructure in place to be able to address whatever the needs are.
Thank you. And Dr. Shaw, please quickly share with us.
I'm conscious of the time as well, and all I can really do is amplify the great points made by my co-panelists. Really appreciate what Dr. Reed said about us needing to be better versions of ourselves. At the very least, we have to be the best versions of ourselves. We've got to approach the challenges ahead with humility, with empathy for each other, and with vision. We know that there are things that are changing right now that are unlikely to ever go back to normal in ways that are good, bad, and neutral. Within the delivery system, contact precautions will never be the same again. Much like HIV/AIDS changed the way we thought about blood, this is going to change the way we think about physical proximity, and so we've got to be thoughtful about that. We're going to change where we provide care and by whom. In the birthing environments, we're seeing, CMS has relaxed waivers on facility fees, on licensure, and that's a real opportunity to try to do what people have been trying to do in this country for a long time, which is to provide pregnant people with choices about where they want to go for care and who they want to see, to provide care much closer to the communities where they actually live. And so I think if we are humble and empathetic and open-minded enough to take advantage of these opportunities, hopefully we can build a better normal on the other side of this.
Thank you. Now I'm going to turn it over to my colleague. Thank you all for your responses. They've been really incredible, a lot of perspective and very thought-provoking. I'm going to turn it over to my colleague, Lauren, just to close us out.
Yeah, just to echo Nikisha, thank you all for your insight. It's really a rich discussion. I think it's the innovation and the commitment you have to your patients and making sure they're receiving the best care possible is phenomenal to hear, and I'm just really grateful for the work that you all are doing. For our participants, we want to thank you for joining today's program. We have recorded today's presentation, and we will send a link soon to registrants. Again, thank you all for your insights on how COVID-19 is specifically impacting our Black, Brown, and Native birthing people, and sharing what you believe these long-term implications will be. We hope that the information that was presented today will be useful to the work that you all are doing and are planning to do. And we hope that this is a time where we can think very strategically about what we need to see systematically in order to provide the best care to all people, and providing a path forward to protect our most vulnerable as we deal with COVID-19 in the coming months and possibly years. So thank you all again for joining us. And with that, we'll say goodbye.